Please enter your name.
Am I audible?
Yes,
Hello.
sir.
Okay, ma. Okay. Good evening. Madam,
Good evening, sir.
Good evening. Good evening.
Good evening, sir. I am not seen in my video. That's why I'm thinking.
Okay.
How
Thank
are you, sir?
Doing well. Doing well. Doing well.
Sir.
How are you, Indra, ma'am?
Fine, ma'am.
Fine.
How are you?
Fine, fine. After a long time, I'm seeing you.
Yeah, we are seeing you. Are you seen? Am I in the video?
Yes. In a car, you are riding with belt, you are running.
Yeah. Yes, correct. Okay, ma'am.
Me.
We will meet soon in person, I think.
Yes.
Lata, ma'am? Lata?
Shall we start, ma'am?
Yes, ma'am. Please start.
Ramalinga sir.
You
Maybe for
inform to
Dr.
Ramling sir and you start.
Okay.
He will join in his
Already sir came.
side.
Okay. We will start. Good evening, ma'am. Myself, Usha Kiran. It gives me immense pleasure to extend to you a very warm welcome on behalf of Narayana College of Nursing, who have clubbed all of us for the World Cancer Day on a theme of Close the Care Gap. World Cancer Day is the one singular initiative under which the entire world can ride together in the fight against the global cancer epidemic. It takes place every year on 4th February. World Cancer Day aims to prevent millions of deaths each year by raising awareness and education about cancer and presiding governments by individuals across the world to take action against the disease. With this note, let me invite second year students to sing a prayer song on this program. I welcome you.
Cancer Day. പക്ഷെ ഇട്ടില്ല ഇതില്
എന്റെ മൊബൈൽ എന്തിനാ
കുഞ്ചരമുഖം ശർഗരസുഖം തമിഴ് ശ്രീവിഘ്നരാജം അജേ സന്തതമഹം താതി സുന്ദരമുഖം അന്ധകാദടസുതം തമിഴ് ശ്രീവിഘ്നരാജം അജേ ശ്രീവിഘ്നരാജം ഭജേ ശ്രീവിഘ്നരാജം ഭജേ भजेहं भजे तमिह श्रीविघ्नराजे सुन्दरमहं कुञ्जरमुखं शङ्करसुदं तमिह श्रीविघ्नराजं भजे सेवित सुरेन्द्र महनीय गुणशीलम् सेवित सुरेन्द्र महनीय गुणशीलम् जपत समाधि सुख वरदानुकूलम् भावित सुरमणिगण भक्त परिपालम् भयंकर विषङ्गमादङ्ग कुलकालम् श्रीविघ्नराजं भजे श्रीविघ्नराजं भजे श्रीविघ्नराजं भजे भजेहं भजे तमिह श्रीविघ्नराजं भजे सन्ततमहं कुञ्जरमुखं शङ्करसुदं तमिह श्रीविघ्नराजं भजे Thank you, girls. And I welcome second years for the welcome song of our institution. With the hands and the songs on the lips, to the temple of love, to the temple of love, we welcome you here, we welcome you here, to the world of NNI, to the world of NNI. The brighter, the lighter, will bind us together. Knowledge and wisdom, oh, service forever, will meet the desire, will make us go higher. We welcome you here, we welcome you here, to the world of NNI, to the world of NNI, to the world of Narayana. Thank you very much, girls. Now let me invite Professor A. Latha ma'am, HOD Department of Medical Surgical Nursing, to give a welcome address.
Good evening to one and all. So the World Cancer Day program has been collaborated with the Department of Medical Surgical Nursing and NSSL in Narayana College of Nursing. So I plead God, Almighty God, to shower His blessing throughout this program. So now I would like to invite Dr. Indra ma'am, Principal, Narayana College of Nursing, for giving this opportunity and platform to organize this program in a befitted manner. So I welcome you, ma'am. Next, I invite Professor Jayanti ma'am, Principal of Sri Narayana Nursing College, for her valuable support and suggestion. So I welcome you, ma'am. Next, I would like to welcome Dr. Trinavakarasa sir, Surgical Gastroenterologist, Consultant in Narayana Super Speciality Hospital. So I welcome you, sir. Next, I would like to welcome Dr. Ramalingam sir, Principal of Allied Health Sciences and Professor of Biochemistry and Central Lab Coordinator. I welcome you, sir. Next, it's my privilege to welcome Dr. Jasmine, Professor in Medical Surgical Nursing Department, and Mother Teresa Postgraduate and Research Institute of Health Science and Government of Pondicherry. I welcome you, ma'am. Next, my heartfelt welcome to Associate Professor Kanta, Department of Community Health Nursing and Research Scholar of Mother Teresa Research Institution. I welcome you, Kanta. Next, I would like to welcome all departmental HODs and faculties, parents of Narayana College of Nursing, parents and dear my students of Narayana College of Nursing. So once again, I welcome you all. So I heartily once again welcome you all for this World Cancer Day program. So thank you.
Thank you, ma'am.
Lata, can I start?
Yes, ma'am. Let me invite
Hello.
Dr. Indra, ma'am. Let me invite Dr. Indra, ma'am, Principal, College of Nursing. As a jewel of our college, with many endeavors in her career, let me invite Madam to present regarding the introduction of this program. Over to you, ma'am. Principal, ma'am.
Okay. Are you audible?
Yes,
Am I
ma'am.
audible to all
Yes,
of you?
Yes, ma'am.
Okay. Good afternoon for everybody. My heartfelt thanks to all the speakers, Dr. Karnavkar sir, Dr. Jasmine, who has accepted my invitation immediately and joined with us without even within one day. I thank you all heartfully, and all of us we know that as we are all in healthcare, all of us we know that today is the Cancer Day, World Cancer Day, which was been celebrated to create awareness among the public as well as among the healthcare providers. Also, we have invited all the parents also to create the public awareness regarding cancer. So most of the time it will be known for only nursing students, but this time, first time we have into parents. So they are also, I think they are also locking down with this. This Zoom meeting. Okay. From 1965, control the cancer in various ways. Once it all W has started this program, cancer control program or am I audible?
Ma'am, signal is
Hello?
breaking, ma'am. Signal is
Usha?
breaking, ma'am. Signal is breaking, ma'am.
Are you hearing me?
Now we are hearing, ma'am.
There is no.
Yes, ma'am. Little signal problem is there.
Now?
Now
Okay.
it is okay, ma'am.
So let me start with simply as I am in travel. I think on and off the signal problem will be there. This cancer means cancer is an abnormal cell division, uncontrollable and destroy body tissues. All of you know that one because of abnormal cell division only. The cancer is spreading in all over body, and almost all the cells or tissues and organs are affected with cancer. We cannot say this part only will get cancer and that part only will get cancer like that. All over, all the organs will be affected with cancer. Whether cancer is curable or preventable means yes, cancer can be curable or preventable.
कनेक्शन भी नहीं है ना उसे।
So we cancer can be curable or preventable provided early detection and proper treatment. Hello,
Yes, ma'am.
Lata.
Yes, ma'am. Yes, ma'am. We can hear you.
Okay. Is it dangerous? Yes, cancer is dangerous because of pain and the treatment modality and the pathological changes going on in our body and symptoms which are giving us more painful, and mainly with the chemotherapy and the radiation therapy, the patients will have more digestive problems, vomiting, weight loss, loss of appetite and tastelessness, more stress, energyless, and clients will lose their hope and feeling of guilty. So it is danger one. Why is it dangerous? Because it is the second cause of death. So cancer is the second cause of death globally. 70% of death is caused by cancer in various places. That is, nearby 1 in 6 death is due to cancer in low and middle income countries. Usha, can you mute all the participants?
Yes, ma'am.
Can
Yes,
you
ma'am.
mute all the participants because
Yes,
some disturbance is there? What are the causes of risk factors for cancer is one is tobacco use. The people with the cancer and using tobacco is getting 1/3 of death, and high body mass index, low intake of vegetables and fruits, and more intake of junk foods which has addicted, lack of physical activities. Is there any genetic mutation? Yes, only 5% of cancer is taking place because of cancer. Genetic.
Ma'am, please unmute yourself, ma'am. Principal ma'am, Indra ma'am. I have muted all the participants. Unmuted. I have muted all the participants, ma'am.
Okay.
Yes.
So, what are the risk factors for cancer? Okay, we will be having environmental factors, lifestyle factors, infection. These 3 areas we can divide the risk factors. Coming to environmental factors, air pollution, water pollution, use of pesticides, use of plastics in various cooking methodology and other things, and radiation. Once we are coming to lifestyle problems, one is smoking. The highest product which is causing tobacco. Use of tobacco is the first cause for cancer, and then alcoholism. Third dietary habits like less fiber intake and more things, and unhealthy dietary habits and physical inactivity. This all coming under lifestyle. And infection, then infection which lead to viruses, hepatitis B viruses, hepatitis C viruses, and EBV, that is Epstein-Barr virus, HIV virus, hepatotrophic virus, human herpes. Sorry, there is again a lot of little signal problem. And coming to bacterial infection, H. pylori, and Campylobacter jejuni, Salmonella typhimurium, Mycobacterium tuberculosis, and Polyporphyrinus zygzwilisis. Here, if we are taking this Salmonella typhimurium is treated, given for treatment also once the patients are having colon cancer. So these are the types of infections what like virus infection, bacterial infections are causing are leading to cancer. Coming, what are the symptoms? We will be telling caution. When the patients or the clients has to go to hospital or need medical help or go for screening means, we will be telling it as a caution for cancer. One is change in bowel or bladder habits. A for a sure or any what abscess or something that does not heal properly, unusual bleeding or disorders, thickening or lump in breast or anywhere in the body, and I for indigestion and difficulty in swallowing, O for obvious change in water or mold, N for nagging cough or hoarseness of voice. Because if these symptoms are there, if the patients are going to the hospital for screening, yearly detection and appropriate treatment is the only one thing which can be keep the patients or curable cancer in that period only. What are the myths about cancer? Cancer is a death sentence. The people has done some sin, that's why they are suffering with cancer. Once cancer came, we will die like that. It is not so. Many of the people with breast cancer or prostate cancer are living still more than 12 years, 13 years, if they are treated properly, yearly diagnosed and treated. You know, all of you, our film stars, Gautami, and one cricket star also still living after treatment. And cancer is contagious. Yes, some other than some virus infections. No, cancer is not a contagious. It will not spread from one person to another person. Cell phones causes cancer. Here, the main reason what the people are telling, radiation. Because of cell radiations, there will be a cancer growth in the body like that. But here, there is no ionizing radiation is happening. So cell phone may not cause cancer. Power line causes cancer because power lines are having extremely low frequency magnetic field, and they are not non-ionizing agents. They will not cause cancer. Artificial sweetener causes cancer. There is no evidence like that. But a study done by Parvati and Ital, but they studied in rat that saccharin causes bladder cancer because of some chemical activities. Cancer surgery causes cancer to spread. It is also a myth. Once surgery is done for fourth advanced stage of cancer, there may be metastasis. That was myth. It was been taken like this. It is not so. Cancer cannot cause spread of cancer. Herbal medicine can cure cancer. Not only herbal medicines, many of the drugs are taken from the herbal, but directly without treating or without doing proper treatment, herbals directly will not cure cancer. Cancer runs in families. It is also not correct. Only 5% of cancers only running in genetic mutation method. It is not so. Cancer always comes back. Yes, death will come back with the cancer like that. Everybody is going to die one day or another day, but it is not so. Nowadays, with the good treatment and good medications and yearly diagnosis and surveillance like that, it is not true nowadays. There is no cure for cancer. Now, many of the treatment, many type of, some 11 type of treatments are available for cancer, and it will be curable and treatable. How to avoid? How to avoid our cancer, or how to prevent cancer? We can take avoid all the risk factors, and real yearly detection and appropriate treatment, and avoid tobacco use. Since 1965 onwards, our governments all over the world is taking a word, no tobacco. But in various methods, tobacco is still in use, which is causing number one cause for cancer. So avoid tobacco use in any form. Then avoid alcohol. They will tell if we are taking 20 ml or 1 gulp, it is medication. Not like that. Alcohol is danger only. It will cause for cancer or other type of hepatic problems. Maintain healthy body weight. That is more important. And eat healthy food. Include vegetables and fruits. And mostly native fruits, which is available according to that season. High fiber diet, plant and balanced diet will help to avoid cancer in all the areas, and avoid junk foods and additives like tasting salt and ammonia added foods, packets like that. And perform regular physical activities and exercises. Vaccinate against viruses like HPV, that is human papilloviruses, hepatitis B, hepatitis C, like that. And avoid that one. Even HIV also causing this. So we have to be away from that infections. Avoid ultraviolet radiations, which is causing skin cancer. Once we are going outside, if at all we have to go in that period, keep some sunscreen and other things. Reduce exposure to outdoor or indoor air pollution. So how we will be live a long life? So yearly detection, awareness of our bodily and systems. Each and small symptom also we have to identify and report to the doctors, so that we will be getting the treatment earlier. So how we will be doing? Only screening. How we will be screening? You know, all of you, for each and every type of cancer, there is pap smear, and for liver cancer and all, there is ultrasound and other things are there. So screening is more important, and access to clinical evaluation is must, and timely referrals are over. It is imperative that patients who are diagnosed with cancer, even at advanced stage, do not lose hope. That is more important. Hope, giving hope and treating with appropriate treatment, the patients are able to live a prolonged life, a quality life for a long period. There are many effective novel therapies and still techniques are there to cure the cancer, like especially like immunotherapy, combination therapy of surgical and radiation therapies, or surgical and chemotherapy are helpful. So in short, although the battle with the cancer is ongoing process, science is making significant headway. So we will be awareness of avoid smoking, tobacco use, as well as alcohol intake, and taking healthy food, doing physical activity. Thank you. Any questions you can ask? Thank you.
Thank you very
Can I
much,
leave?
ma'am. Thank you very much, ma'am. Now let me invite our next speaker, Dr. Tirunavukar sir. Sir is a consultant in Narayana Medical College Hospital as a gastroenterologist, and he retired as a professor of gastroenterology in MMC and HOD Department of Gastroenterology at Peripheral Hospital, Chennai. Sir got 46 years of extended uninterrupted teaching experience for MBBS, MS, MCH, and nursing. Is an honorary syndicate member in St. Teresa University, Caribbean. Has been awarded fellowship from Royal College of Surgeon, England, Edinburgh, Glasgow. He started Department of Gastroenterology at NMCH. So I'm very glad to see you in this program, sir. Over to you, sir.
Thank you very much for the introduction. Respected Dean and Principal Dr. Indra, Head of the Department of MSN, Dr. Lata, and all the faculties of nursing and my dear sisters. I would like to tell you a few words about the care of the cancer patient, right from the time of diagnosis, treatment and post-treatment and follow-up. In a nutshell, I'll tell you, I'd like to have my screen. I'd like to have
Yes,
my
sir.
slides.
Yes.
So what's cancer? The word was used by Hippocrates. Is nothing but kakinos. That means a crab. A crab has got a knack of digging and digging and digging and digging, make its area bigger. Like that, the malignancy has got a knack of digging everywhere and extending to the near tissues, also getting spread via the bloodstream as well as the bloodstream and as well as the lymphatics, and cause an distended metastasis and so on. So that is why it is called a crab. It has got a potentially unlimited growth if not treated. You must understand, a cancer will not stop by itself. It has got an extended growth. It's always have got a potential to grow and multiply. Next slide, please. Next slide. Shall I manage? Estimated number of people living with the disease is 2.25 million. Every year, about 11 lakh and odd people are diagnosed with cancer. The cancer-related deaths are about 7 lakhs and odd. Predominantly, it's a oral malignancy. And in women, predominantly the breast and ovarian malignancy. Next slide. Sorry. Next slide. Previous slide. Estimated. Next slide. This is the most common cancers in India, but the slide do not show. Being a gastroenterologist for over a period of 3 decades, I've seen the increased number of malignancies both in women and men, in liver, pancreas. This is because of the longevity has increased. The investigative modalities have been thoroughly refined. So we got right from the tumor markers to the level of the cross-sectional imaging and end-ultrasound biopsy and so on and so forth, laparoscopic biopsy, targeted biopsy. This has increased our level of diagnosing the malignancy. Of course, the longevity of the individual also has increased. So I have seen a gross increase in gallbladder, liver, and pancreatic malignancy, which is not shown here. Apart from the routine, I'm telling you this, they also can come with the same extent. Next slide. Next slide. What are the causes of cancer? Indra has spoken very well about the cause. She's almost covered half of gastroenterology. I was listening to her. That says how much knowledge she has. I will just briefly touch certain things. Next slide. All cancers are environmental. Environmental include habits. Environmental includes the feeding habits. Environmental includes the lifestyle, everything. The majority of the malignancies are due to the environmental factors. You know, certain amount of change in the emotional outburst of an individual can also precipitate a malignancy. So psychologically also it can cause. That is what environmental. Smoking, of course, is a deadly one. Tobacco chewing, again, the commonest form of cancer for oral malignancy. Betel nut chewing, very common in the village folks. Alcohol, yes, alcohol do cause malignancy of the liver and pancreas. Fat, that means the lifestyle modification has changed a lot. Sedentary life, no exposure to sunlight, no walking, taking a lot of junk food, as Dr. Indra has said, has increased the fat. The fat is a potential oncological matter. Then lack of physical activity, hereditary. One can turn and ask me, if I avoid all this, can I be devoid of malignancy? No. In about 10 to 20% of the patients have got a knack of getting malignancy because of their chromosomal abnormality. And some of the malignancies do occur in families. Some of the malignancies occur in a pre-malignant condition, which is not explained by any etiological factor like ulcerative colitis. Also, the benign disease which can turn malignant is a polyposis coli. I can talk more about gastroenterology only because I am exposed to that. Next slide. These are the warning signs of malignancy. A nursing staff, she can understand that she excels from others. A nursing staff should be aware of more than 60 to 70% of what doctor knows. Then only it will be helpful for the doctor, and she will definitely claim a very good respect in the society. Change of bowel or bladder habits can be a sign of colorectal malignancy. A sore throat or a skin lesion that does not heal can be a malignancy arising from the mouth to the skin. Unusual bleeding and discharge can be from the bladder, can be from the vagina or the rectum, cervix, and colorectal malignancies. Suddenly, if you notice a thickening or a lump, especially for females in the breast, you must always rule out the possibility of a malignancy or the breast malignancy. In a male, a testicular malignancy. Indigestion or dysphagia can be a part of any malignancy because the malignant cells and the necrosis that occurs in the malignancy causes a sort of dyspepsia and indigestion. But usually it is due to a laryngeal malignancy or esophageal or a mouth cancer. Obvious change in a wart, if you've got a wart or a mole, suddenly it is becoming bigger. It become itchy. It starts bleeding. Then it could be a malignant transformation of that benign disease. Nagging cough and hoarseness can be anything from the larynx down the bronchus into the alveoli of the lungs, a malignancy. Next slide, please. How is it detected? Next. No. Next. No. Previous. Yes. You must spend time with the patient and patient relatives. You must spend time in asking a proper history. The moment you listen, you should not write ultrasonogram, this, that, go, do a blood exam. No. Majority of the patients hide their symptoms because they will be the breadwinner. They don't want that disease to take over them from the breadwinning, so they will not reveal. But the relatives would have watched a change in his physical activity. So a thorough history taking and talking to the relatives who are very close with him will guide you to a place where he is probably suffering. Of course, a physical examination, the biopsy, you must do and prove that it is histopathologically a malignancy wherever it is possible. If it is in the stomach or esophagus, you can put in a scope and take it. If it is a prostate, you can do a prostatic biopsy and do it. If there is a breast, you can do an FNAC. If it is a thyroid, you can do an FNAC. But some of the malignancies do not require a histopathological examination like liver and pancreatic malignancies, because in some of the cases, we will not be able to establish a histopathological examination. So we go with other guidance like a CT finding and tumor markers and how he behaves and all so on and so forth. But you require a tissue diagnosis if you're going to condemn the patient once for all. that this man is not fit for anything. Or if you're going to attribute the latest multimodality treatment like a preoperative neoadjuvant therapy and so on, or trying to reduce the disease by downstaging the disease by giving a radiation or a chemotherapy, in those cases, you require a histopathological examination so that you can go ahead and do it. CT and MRI, very handy. More than 80 to 90% of the cases can be diagnosed by a CT and MRI. Radionuclide scan is of course useful, but PET CT and PET scan has come in a bigger way that can be used whenever it is required or whenever you're going to condemn a patient, whenever you think there is an extra primary disease elsewhere. Next slide. How can cancer be treated? Cancer, the treatment is, next slide. Next slide. The treatment is, I remember Professor Vasudevan Nambiar, who was my teacher in MS, used to say, separate the malignancy from the individual. Separate it. That means cut and throw whenever it is possible. You cut it to a certain extent that you do not leave a macroscopic and microscopic tissue there. And the histopathology should tell you that you have gone well away from the tumor. The resected margins are free. It is an R0 resection. Also, the harvesting of the lymph nodes you have done thoroughly. Now, one more step it has gone ahead as some of the malignancies have got a knack of seedling in the liver, which are amenable to your knife, provided the general condition of the patient is there. So your aim as a surgeon is to separate the malignancy and the patient. What are the other roles of surgery? It can be palliative. It can be palliate pain, palliate obstruction, palliate jaundice. Whichever is there, if you can palliate without giving a cure, you can do a palliative surgery. For example, when I was a student, there used to be one thing called toilet mastectomy. Nowadays, do not come to that level. The tumor comes, it bursts. It produces a fungating mass in front of a chest of a female. So we do a toilet mastectomy. So nowadays it is become historical because the people come to the doctor early and get it done. So the role of surgeon is very important in eliminating malignancy or giving a palliative relief to the person whenever it is required, as and when it's required. Next slide. Next slide. Chemotherapy. Certain diseases were not amenable to chemotherapy at the earlier years when I was a student. Now, the repeated trials and finding out of so many other monoclonal variety of chemotherapeutic drugs and all, many of the diseases are amenable to chemotherapy. As a sister, you should know the chemotherapy can be given perioperatively with or without radiation if you're trying to downstage the disease. That is called a neoadjuvant therapy. So when somebody may ask you what is neoadjuvant therapy? Neoadjuvant therapy is nothing but giving chemotherapy with or without radiation prior to surgery to bring down and sterilize the area around the tumor so that it will come for the knife to a surgeon. So that's called neoadjuvant therapy. Nowadays, people are doing a perioperative chemotherapy also by giving irrigation and local so on. Next is adjuvant therapy. What is adjuvant therapy? You should know when they have completely removed the tumor. There is always a possibility some of the tumor cells are circulating in the bloodstream or the lymphatics. By your skews pressure during surgery, by your maneuverability, it would have gone. It will be subsculating. To sterilize those things, you must give chemotherapy. And in case the patient has got a residual disease by your histopathological examination, again a chemotherapy will go and kill those cells. These are called adjuvant. Then comes the palliative. The palliative chemotherapy is not for any surgery. It is only to palliate the symptomatology of the patient and prevent further spread of the disease locally. So that is where the adjuvant, the palliative therapy comes. Some of the cancers which are completely condemned will be treated only by a palliative chemotherapy if it's required, if the general condition of the patient is good. And some of the cancers have got a total cure by chemotherapy. You should know as a staff nurse, a surgery is not required. There are certain malignancies which can be totally cured by a chemotherapy. So it's called curative chemotherapy. Next slide. Next slide. Radiotherapy, of course, a combination or alone can be given. This again can be a neoadjuvant form. It can be perioperative form. It can be a adjuvant form or a palliative form. So all the four forms like a chemotherapy, only the radiotherapy, but some depends on the organ involved, depends on the type of malignancy that has come. Will it amenable to the radiotherapy or not? We should know. Now, majority of the cases are amenable to chemotherapy because we have got chemosensitizing drugs that has come as for the form of chemotherapy. If you give that, they radiosensitize the tissues and go on. One is called 5FU. Next slide. Cancer care. This is more important. So far, I have been talking so that you should be an excellent staff rather than an average one. That's why I thought I'll put a little bit of subject in your mind. Now comes the preoperative care. Don't yell at the patient. Be very, very cordial and loving to the patient. The patient has come with a suffering. You may have so many problems in your house. I've seen not only you, doctors also yelling at the patient. I've seen many number in this 45 years of journey in the medical field. Be very, very affectionate towards the patient. Understand what they're undergoing. Give them the psychological support. Always tell them that they will be all right. Initially, don't tell them they've got a malignancy. Try to tell some of the senior member in the family so that they will slowly infuse, or the people over a period of time, the patient himself will understand that he is coming with a malignancy. You should not say, you're having malignancy. Don't say that. It is a very disheartening thing, and it is something like a death sentence even today everybody feels, even though it is treatable. So be careful in handling. I will only stress on the psychological aspects. You must counsel the patient. You must give them the psychological support. You must understand, when I see that sister, I become all right. The patient should feel like that. Whenever he's having an excess problem, he can come and see you. Sister, I'm feeling like this. So psychologically, you must support them. You must give them high caloric, high protein, and a low residual diet. Give little bit of information what he will have to undergo post-operatively, and also a smaller complication which will not hurt the patient. You can say you're likely to go that, so that he'll be mentally be prepared. Oh, I'll have like this. There's nothing to worry. Sister has already told me. Prophylactic antibiotic according to the medical advice. Other things, you monitor the urine output. I had an excellent staff when I was a postgraduate in MS. Everyone was going scot-free. That lady called me around 10:30 in the night and said, this patient do not have an urine output, sir. What should I do? Then I said, keep your hand over the lower abdomen and see whether the bladder is distended or any mass. She's an excellent staff. She traveled with me for almost till my retirement. She was one of my best theater staff. She said there is something like a bulge I could see in the suprapubic region. I know the catheter has got blocked. I went to that. I changed the catheter. The patient was totally relieved. So why I'm saying this small bit of happening is, you must understand when the urine output is not good, you must always inform your medical officer. Fluid and electrolyte observation. Every staff should know how to put in an IV line. I don't want to say which hospital. I was recently admitted with a COVID infection in another hospital. These children literally digged my hand out for getting a vein. And almost all my veins have been thrombosed at the time of discharge. Then I had to tell the management, teach your sisters how to put an IV line. That's what it is. Next slide, please. Next slide. Post-operative care, be cordial with the patient, make them walk, do little bit of exercises, frequent small amount of meals, assess the wound dressing. You yourself can see if it's foul smelling or if the effluent which is coming out of the stoma is change in color. Empty the pouch when the bag is one from the bag into the patient. Next slide. Next slide. Am I audible? Next slide. Post-operative care, mild pain. No, previous slide. Previous slide. Previous slide. Hello. This is what. Mild pain, you can do a non-steroidal anti-inflammatory drugs. No, next slide, please. That's all. Moderate pain, we can give weak opioids. Severe pain, morphine. Opioids and morphine should not be enough to handle it because pilferages of such medicines who are around, maybe a doctor also, is so much that you must have an account of everything, and you must be handled by an experienced senior staff nurse. Infection, you can suspect an infection. The patient has got a fever. You can give antibiotics with the consultant's advice, and you wash your hands so that you don't infect the patient. Next time. Next slide. Am I crossing my time? Can I take 5 minutes more? Hello?
Yes, sir. Yes, sir. Please carry on, sir.
Yes, sir.
Can I take
Yes. Yes, sir.
5 minutes more?
Yes, sir. Yes, sir.
Thank you. Monitor for complication. Monitor for the complications in colon and rectal stoma related complication. Stoma therapist is basically a nursing staff who gets trained by stoma. I had very good stoma therapist. One, Dr. Saroja sister, she is no more. The other one is Selvi, who is an experienced enterostomal therapist, took training in Madras. So stoma therapy, someone uncle said, leakage, prolapse skin excoriation, in a breast malignancy, they extensively mobilize the flap, can go for a flap, underneath that you can get a serum collection, or if there is an extensive lymphadenectomy done, lymphedema, thyroid malignancy. This again, I got a nice example, who was one of the senior sister when I was about to go for my MCH. So I think last few weeks before my call around late in the night that the patient is not able to breathe. There is some type of woosting from the neck. From there, I asked her to cut off all the sutures, leave it open. If there is a bleeding, keep a small pack with a pressure. What happens is when they do a thyroid, the blood collects if there is a bleeding. Underneath the strap muscles compresses on the trachea. So the patient is not able to breathe. So next slide, I'm going to show you how every staff should know that how to do this maneuver and pulmonary complication. Next slide. See, this is a stomal prolapse. This is the skin excoriation. You can see the flap necrosis when they extensively. No, previous slide, please. Necrosis. This again, this is the lymphedema, normal and lymphedema. That means plenty of lymph nodes have been relieved. What you must do in such a case as a staff, keep the hand elevated, put a saline stand by nearby, put a pad around the rest and make it hang so that the edema will come down. Next slide. Next slide. Next slide, please. I'm not getting the next slide. Should I do? Am I audible? Next slide.
So so little network issue is there, sir, from your
No.
side.
Next slide, Amma, please.
Is that okay, sir?
Yeah. This is the management of hemorrhage in the post-thyroidectomy. Go to the previous slide. Go to the previous slide. Go to the previous slide. I'll
Yes.
finish it quickly. Don't get bored.
No, sir.
See, remove the stitches, empty the clot, keep a bandage, and call for the help from the medical officer. You will save the patient. Next slide. When it's time, you tell me and stop it. Next slide. Chemotherapy, very, very important. Everyone should know how to do an IV line. Now the technique has become easier in the Seldinger way. It comes with a nice cannula. You just prick the vein, enter into the vein. Don't shove the needle along with the needle. Withdraw the needle and push the cannula alone inside. It will go. These are various methods of giving a chemotherapy: IV, oral, intrathecal, topical, intraarterial. Everything you will have to maintain an absolute aseptic maneuver. Otherwise, you will go in for inflammatory complication and infectious complication, which will further deteriorate an already sick patient. Next slide. Next slide. Next slide. There's some problem for you. Next slide. The IV routes are the subclavian catheter, chemoports, and peripherally inserted central catheter. It should be aseptic. Aseptic should be maintained. You should tell the people not to disturb that. Otherwise, repeated things will happen. Major complications, extravasation. One important thing I want to tell all the nursing staff are never test the patency with the medication what you are injecting. Even it may be an antibiotic or a chemotherapeutic agent. Always try the patency of the thing using either a distilled water or a normal saline. Watch for anaphylaxis, preparing everything you know. Next slide. Role of nurse, important member in the multidisciplinary team. She is the backbone. Implements chemotherapy, adjusts the dose. Psychological impact of the cancer is better dealt by the staff nurse. Patient compliance has become more if the staff nurse is very helpful to them. Safety on oral therapeutic drugs, support throughout the treatment course, predict toxicities, especially when you're giving at home. You must expect the toxicity. Next slide. Next slide. Side effects, infection, oral hygiene becomes bad, nausea, vomiting, loss of appetite, change of taste, sore mouth, constipation, diarrhea, alopecia. This is what everyone feels. Oh, I lost my hair. You will have to be supportive to the patient, especially if the patient is a female, that she will gain back her hair back. Otherwise, you must convince her and what do you say? You must counsel her to go in for a wig at an earlier stage. Fatigue, infertility. Next slide. Next slide. Ramalingam is waiting to talk. He is impatient.
No problem, sir. I am
Common
enjoying
side
your
effects.
lecture. I am becoming a student. I am enjoying the lecture, sir.
Thank you. Thank you. Thank you. So other thing, common side effects is a leukopenia. Leukopenia causes that's called agranulocytosis. It causes the patient exposed to infection easily. You must do barrier nursing. You must always use glove, put on a mask, never wear. All the hair is properly tied and it is not hanging free, no flowers inside. Everything should be followed so that the patient will be fine. Then thrombocytopenia, these are the things you avoid. If the patient wants to shave, avoid razor shaving or make some other person who is expert in doing this. All these things, that's all. You can read yourself. Next slide. Next slide. I'm coming to an end. Don't worry. Next slide. I asked Lata sister, can I go ahead for a few minutes more? She has
Yes, sir.
permitted me.
Yes, sir. Yes, sir. Yes, sir. Yes, yes.
Neutropenic precautions. Staff and physicians, no plants or flowers. Never encourage the nursing staff to wear the flowers during their duty. Damp dust only. No room maintenance. Keep closed. No, do not do a room maintenance when the patient is inside. Must be dust-free. Disinfectant wipes between the patient. For essential purpose only, you must transport. You must always transfer to the N95 respirator. Mask for all room entry if recovering from a illness. Visitor check with nursing for the mask instruction. When you enter or wash hands, apply soap to the wet hands, dry hands, and use it with the dry paper towel. I think you can follow it. Next slide. Next slide. I told you nausea and vomiting.
Yes.
This is more of a theory. You can just understand what is nausea and vomiting when the patient requires a rehydration, when the patient requires the medication to stop this, when the patient requires a help from your senior medical officer. Next slide. Next slide. Next slide. Chemotherapy induce diarrhea, every sister should know. Less than 4 is a baseline. 4 to 6 per day is grade 2. More than 7 is grade 3. More than that is grade 4 and life-threatening. It requires an urgent intervention. All these things you should know, because all the time the medical officer may not be there. The nurse should see and advise the doctor such is the thing, especially people working in the oncological setup. Next slide. Next slide. Next slide. Next slide. No, this you don't worry. How to treat this, you don't worry. Go to the next slide. Alopecia, psychological support, reassurance, encourage to acquire before hair loss occurs. Encourage use of attractive scarves and hats. This is purely with you, with the nursing children. Next slide. Next slide. Next slide. Anaphylaxis, you don't worry. Every sister know what is anaphylaxis. You must give always a test dose before giving anything. Go back to the previous slide and inform your medical officer quickly and treat the anaphylaxis. I think all the sisters know about all this. Immediately raise the foot under the bed so that the venous return improves to the heart. The attack comes down. The first and foremost the staff should do is raise the foot under the bed. Rest of the things your doctor will come and help, but identify. Always a test dose is mandatory whenever you're using a new drug. And the history of drug reaction must always be asked from the patient, because majority of the injections are given by sisters only. We should know that. Next. Next. These are the various types of somatitis. Patient education is must. Use of soap, toothbrush, avoid mouthwashes containing alcohol. Chlorhexidine wash to decrease the risk of hemorrhage and protection of gums and from the trauma. This is what you must advise them. Every sister will attend on the mouth in the morning, especially the patients are in ICU or not able to attend themselves or in the oncology wards. Every sister should know this. Next slide. Next slide. Next slide. Nutrition, avoid raw or uncooked meat or poultry or seafood, unpasteurized or raw milk, raw or undercooked egg, unwashed fresh produce, soft cheese made from unpasteurized milk, cold hot dogs and deli meats. Food to eat: meat, poultry, seed, a firm yolk, washed, fresh or cooked produce, hot cheeses or chopped cheeses made from pasteurized milk, re-heat dog and deli meat. The oral hygiene prior to thing, vitamin supplements, giving fluids, counseling regarding nutrition. Next slide. So much to talk about cancer care, especially when are you hearing me?
Yeah,
Yes, sir.
now we are
Hello.
hearing you, sir.
Yes, sir. Yes, sir. Yes, sir. We are hearing. Yes, sir.
Are you hearing me?
Yes, yes, sir. Yes.
Put on the last. Now is the radiotherapy, the internal radiation, external radiation. Next slide.
Yes, sir.
Next slide.
Yes,
Next
sir.
slide. Slide.
Yes, sir.
Can you hear us, sir?
Can you hear,
Some
sir?
problem. Next slide. Some problem. You change that slide, Amma. Go to the next slide. Nursing care. It must be a private room, limited visitors, less than 30 minutes. From a distance of 6 feet, they must see. Radiation warning sign must be there. Every person who enters, especially the sister working doctor, should have a dosimeter with a film badge to see how much of radiation they got exposed. Lead aprons are better. Preparation of the skin over the targeted areas are better. Next slide. Next slide.
Yes, sir.
Now we have come to an end. Tattooing of the target areas. Don't expose the area to sun or heat. Very important. Soft clothing. Avoid tight clothes. Don't apply lotions, ointments on targeted areas. Very important. This is all nursing care only. Next slide. Next slide.
Yes, sir.
Conclusion. Oncology staff is a very great person. To work in an oncology department is a dedication required by every staff, because 60% is dependent on the nursing staff only. Rest 40 only, rest of the things. They are much respected for the technical information and the communication skills. Throughout the world, the person who is working in oncology is much respected. I've seen myself in UK. Nursing is a component of multidisciplinary approach. She is a part and parcel of the multidisciplinary approach towards a malignancy. Promote psychological and social well-being of the patient. This is your duty. Pre-operative, you've got a role in pre-operative, intraoperative, post-operative chemotherapy and radiotherapy. So you've got role everywhere. This talk I've given for general, especially so the people who are going to work or were working or were always having a work with the persons and see.
Hello, sir. Hello, sir.
Okay, next slide is only a thank you slide. Thank you. Any question?
Thank you very much, sir. It was very informative. All of us, with very enthusiasm, we listened the class, sir. We got very new points. And thank you very much for your time, sir.
Okay. I want to talk to just.
Yes, sir.
Hello, sir.
Hello, sir. Hello, sir. Can you hear, sir?
ఆయనకి డేటా అయిపోయిండొచ్చు. స్టాప్ అయిపోయింది. సార్ వెంటనే సార్ will reconnect, I think. Okay. Please, I am inviting Dr. K. Ramalingan. Ramalingan sir, Principal, Narayana College of Allied Health Sciences, and he is the Central Lab Coordinator in Narayana Hospital. So I am inviting sir for presenting the topic on biochemistry of cancer and laboratory diagnostic of tumor markers. Sir. So I am inviting for your presentation.
Hello. Thank you. My voice is audible, madam?
Yes, sir. Yes.
Please share the slide. I'm going to talk about the basic of the cancer cell and its diagnosis. I'm not talking much about the clinical aspect because I'm basically a biochemistry. I want to talk the basics. Everyone knows that cancer cell is nothing but an uncontrolled growth of the cell. So if we see the importance of this biomedical importance, what is the biomedical of the cancer? Cancer is a major health problem affecting humans throughout the world. So several types of cancer affecting the major organs like lung, brain, kidney, colon, breast, esophagus, and stomach, as already I was detailedly given on that, have been identified. At the same time, the rate of incidence of cancer of particular organ is particular population depends on several factors: age, sex, dietary habits, environment, geographical location, genetic makeup, culture, physical exercise, etc. Example, in India, oral cancer is more than in Japanese and Chinese people. Colon cancer is common in advanced countries. So like that, the region-wise, geographical wise, also the cancers was varied. Lung cancer is common in smokers. Old people are more prone to this type of cancer and lung cancers. Brain cancer and blood cancers are common in children. Men above 50 are prone to prostate cancer. Women above 45 are prone to breast, ovarian, and cervical cancers. So understanding the importance is very how it was spread geographically, racially, environmental factors, genetic makeup, physical activity, everything here determining factors. Next. Next slide, please.
Next, sir.
Yes. It's not displaying, very late display maybe.
Yes, sir.
So same biomedical importance, another slide will be there. Just come. I'm not seeing that slide. Shall I share the screen with you?
Yes,
The
sir.
permission?
Just a minute, sir. I will make you as a co-host, sir. From your side, also you can share, sir. Sir, I made you as a co-host, sir. You can share from your side.
Okay. Able to see the screen?
Yes, sir. We can see, sir.
So the rate of incidence of cancer of particular organs varies from developed countries to developing countries. Lung and colorectal cancers are high in developed countries, while stomach and cervical cancers are more in developing countries. Further, in India, pharyngeal cancers are high in Western India, whereas stomach cancers are more common in Southern India. Again, in India also, Western India having certain type of cancers, and South India it has a different scenario. So, what is made cancers? So, nothing but growth of all type of cells is usually the cell growth is controlled in the body by various molecular mechanisms. The cell, once it is grows to its size, with a lot of regulators will stop the growth. Even the one cell touches the other cells in the tissue. Those are the signals to stop the growth. And once the cell functions over, the cell will to die. That's called programmed cell death. It's called apoptosis. So every cell except brain and cardiac cell will undergo apoptosis, that is cell death. So whereas in cancer cell, it was not happening. There is an uncontrolled growth, proliferation, which leads to malignancy. They are not obeying the apoptosis program, cell death program. So cancer is a malignant growth, uncontrolled growth of cells. Malignant growth of cells is also called as tumor. Cancer of a particular organ or tissue develops when the cells of that organ have lost growth control. In addition, cancers has other abilities. Same time, the cancers also having other abilities like invasion, metastasis. So the metastasis is nothing but by circulation, the cancer cell reaches the other part and also spread the cancers in this other region. So metastasis. So this is a basic nature everyone knows. Only one thing we don't remember, the cell growth was highly controlled in normal individuals. Normal individuals, various molecular mechanisms stops the uncontrolled growth. A lot of factors involved there. Programmed cell death also was planned to destroy the cells once the function's over. But here it does not happen. There is a immortality of the cells that makes the cells to grow behind the control. See the nomenclatures of cancer cells. Generally, cancers are named as according to the organ affected. However, they are classification based on the embryonic germ layers from which tissues or organ is derived. Say, for example, carcinomas. Carcinomas are the cancers of cells or organ derived from either ectoderm or endoderm cancers of epithelial tissue, nervous tissue, glands, etc., named as carcinoma. Example, adenocarcinoma indicates the cancer of the glands. Squamous cell carcinoma, cancers of squamous cell or epithelial tissues of epithelial tissue. Gliomas indicate the cancer of brain nervous tissues. And sarcomas refers to the tissues of mesodermal origin. Generally, cancers of bone, cartilage, connective tissue, muscle, etc. are called as sarcomas. Example, osteosarcoma, which indicates a bone cancer. Fibrosarcoma, it is connective tissue cancer. So there's some nomenclatures. And it comes to the cancer genes. See, genes are nothing but, it is a DNA which causes the expression of a proteins. So similarly, the cancer causing genes also present in all people, all individuals. Only thing is, they are stimulated, they are expressed when the cancers initiated. So if terms oncogene, it's nothing but they are genes responsible for, oncogenes are genes responsible for development of cancer. Proto-oncogene, this is nothing but precursor of the oncogene. The oncogene is an activated form of cancer producing genes. Proto-oncogene is a sleeping oncogenes. Every individual having this proto-oncogenes. The factors which stimulate the proto-oncogene to oncogene called carcinogens. Carcinogens are factors. They are biological, they may be chemical, they may be physical factors which stimulate the proto-oncogenes, carcinogens. And our body also, every system was protected by tumor suppressor genes also. The tumor suppressor genes are genes that protects the body by preventing the expression of oncogenes. So they are present normal healthy people. Products of them prevent cancer development. So tumor suppressor genes are actively working in all cells so that it will prevent the oncogene expression. So any defect or any damage happen to tumor suppressor genes, automatically there will be activation of oncogenes. So these are the genes term mentioned in the cancer. Carcinogenesis. So carcinogenesis is nothing but a development process of the cancer. You see, by several ways carcinogenesis occurs in human and other animals. Usually they are named accordingly causative agent or factor. Different types of carcinogenesis are given below. So first, biological agent that causes cancers or biological carcinogenesis, usually viral. Virus will cause this biological agent. Virus is a biological agent which causes carcinogenesis. Some DNA and RNA viruses are carcinogenic, and hence they are called as oncogenic viruses. When normal cells are cultured with oncogenic viruses, the normal cells are transformed into cancers, tumor cells. If you keep the normal cells and the culture and the DNA, RNA viruses in the cultures media, the oncogenes part of the virus transform to the normal cells. So oncogenes of the virus are responsible.
Slides are not changing, sir.
Oh, slides are not changing. Yeah. Which now where we are? Which slide?
So we are in biomedical importance itself, sir. Second, I think it is the third slide.
I crossed 4 or 5 slides.
We are seeing, sir, somewhere it is a problem like that we are thinking.
No, I'm sharing. You told it is showing. Okay, then you share the slides otherwise. Slide sharing is not happening. Biomedical importance crossed. I crossed cancer slide, nomenclature slide. I crossed this oncogenes. I mean, yeah, you are not able to see the slide, huh?
No, sir.
Here it's showing is you are sharing the screen option is there. Then otherwise you share that screen otherwise. What can I do? I will stop sharing, you share.
Yes, sir. Yes. Can you see the slide now, sir?
Now I am able to see the slide. I will start from here. Back. Cancer.
Next, sir.
Previous.
Yes.
So again, I will repeat. If you time permits, I will repeat 5 minutes. because so the cancer cell. Okay, please. So based on the name of the cancers, it was already classified into. Again, you are changing the slides. Okay, we'll start from here. Please wait.
So, just a minute, sir. Is that okay, sir?
So generally, cancers are named according to the organ. I told. Carcinomas, for example, they are the cancer cells of organ derived from either ectoderm or endoderm. They are called carcinomas. Example, adenocarcinoma, which indicates the cancer of the glands. Squamous cell carcinoma, which indicates the squamous cell or epithelial tissue cancer. Gliomas, which is nothing but cancer of brain nervous tissue. Next slide. Yes. And sarcomas refers to the cancers of tissue of mesodermal origin. Generally, cancers of bone, cartilage, connective tissue, muscle, etc. are called as sarcomas. And here, osteosarcoma, it indicates bone cancer. Fibrosarcoma, which indicates the connective tissue cancer. Next. Here it indicates the cancer genes. What is the cancer gene? The genes which they are the precursors of oncogene. They are converted to oncogene by activation. Every individual is having this proto-oncogene in our body. Only by activation they are converted into oncogene. The activation may be various ways. Carcinogens can activate. Tumor suppressor gene function loss also can activate. Because the next part is tumor suppressor gene. They are the gene present in the normal healthy people. The product of them prevent the cancer development. Because the tumor suppressor gene always stop the conversion of proto-oncogene to oncogene. So any mutation happen in tumor suppressor genes also, there will be a conversion of proto-oncogenes to oncogene. Or carcinogens, chemical carcinogen, biological carcinogens, or physical carcinogen also may activate the proto-oncogene to oncogene. Once the proto-oncogene converted to oncogene, oncogene will produce the cancer conditions in the cells. Next. Previous one slide was done. Carcinogenesis, very important process. It's nothing but cancer conversions from normal cell to cancer conversion process. In several ways, carcinogenesis occurs in humans and other animals. Usually, they are named accordingly causative agent or factor. Different types of carcinogens are given mentioned here. Biological agent, chemical agent, physical agent. Biological agents means usually biological carcinogenesis. So DNA, RNA viruses are carcinogenic. Some virus will have DNA, some virus will have RNA. So they are called as oncogenic viruses. When normal cells are cultured with oncogenic viruses, the normal cells are transformed into cancers. For example, hepatitis B virus infection happened to the liver cells. The liver cell will undergo carcinoma. So HPSAG positive patients, later they develop the hepatocellular carcinoma. So it's an indication of biological agent, biological carcinogens. Oncogenes of virus respond for development of the cancer. Example, hepatitis B virus, which causes liver cancer in human. Retrovirus also causes cancers in human. Yet retrovirus is RNA containing viruses. Next. So similarly, chemical agents also can cause, chemical substance can cause mutation in DNA. They call mutagens. Sometimes this mutation in DNA may convert normal cell to cancer cell. Then they are called carcinogens. So chemical agents just stimulate the DNA to convert the normal cell to cancer cells. Cigarette smoking is a chemical carcinogen, causes lung cancer in human. Aflatoxins are carcinogen. Nitrosamine, benzopyrene chemicals, asbestos sheet, which we are putting into the roofs. Asbestos sheet also causes cancer. They are characterized as a chemical carcinogens. Lot of chemical carcinogens we are exposing every day. Only I listed few. Lot of food adulterants are containing chemical carcinogen. The reusing of the oil is a chemical carcinogen. Lot of carcinogens. Those carcinogens may stimulate the DNA, RNA of the oncogen, proto-oncogens to convert it into oncogens. So carcinogenesis may happen either physical, biological, or chemical. Next. Physical agents, UV exposure causes mutation of DNA of the skin cells. Mutant DNA mediates carcinogenesis by activation of oncogen, which leads to development of cancer of skin or multiple tumor of the skin. Usually radiation, X-ray, UV rays, gamma rays exposure can causes usually skin cancers. And next slide, please. Now we have come to the tumor markers. I will finish in 5 minutes. No problem. No, sorry for the delay on previous slides. So tumor markers are nothing but a marker which gives about the information of the tumor cancer markers. So cancer markers are cancer or malignant cells produces abnormal substance. Usually these substances are not produced by normal cells. Tumor markers are nothing but they are a substance which is usually produced in low quantity or may not produce by the cells. Normal cells does not produce or may produce very little quantity. But the cancer cell will produce those markers in high quantity. So that itself, the blood, you can test those markers. In the blood, those markers will be circulated. It indicates particular organ is affected by cancer. So it's nothing but diagnosing. So diagnostic importance. So the abnormal substance produced by the cancer cells are enzymes, hormones, or maybe proteins. So usually they may be normally lesser in quantity in the blood. But in the cancerous condition, these substances may be in very high quantity. These substances are released in the blood by cancer cells. As a result, their level in the blood rise. Measurement of these substances in the blood or serum provide the useful information about the cancer. If you take the blood sample of the cancer patient and fill the blood sample of the normal patient, if you compare, for example, alpha-fetoprotein, so it is a liver cancer marker. The alpha-fetoprotein usually won't present in the adult cell, normal cell, whereas the liver cell cancer patient, the blood will contain huge amount of alpha-fetoprotein, 1000 units like that. This indicates the liver is affected with the cancer. It's a confirmatory test. Hence, they are called as tumor markers. Nowadays, measurement of tumor markers is blood is the integral part of oncology. So it is once you are suspected cancer, the markers will be immediately tested, and that is confirmed the cancer whether it is there. So those type of tumor markers every day we are analyzing in our hospitals from the blood samples, and it was reported. So like biopsy, this is also a diagnostic tool for diagnosing the differentiated different cancers. Next slide. Tumor markers measured used in detection of cancer. These are uses. Tumor marker measurement is used in detecting the cancer, diagnosis of cancer, prognosis also. That after treatment, how the markers are elevated, whether it decreased or increased. This is a prognosis. Determination of cancer stage, whether to stage 1, stage 2, stage 3, like that it will be useful. And it will be used for the determination of location of cancer in the body. So where exactly the cancer is affected. For example, if it is AFB, it is a liver cancer. It is, for example, For carcinoembryonic antigen, it is a colon cancer. Like that, to determine the location of the cancer. Also, determination of organ involved in the cancer, and also used to monitor the cancer therapy. So these are the various usage measurements uses for of the tumor. So it will be very much useful for the treatment, diagnosis, prognosis, finding the location of the cancer site and which organ is get affected. Everything we can able to know by measuring the tumor markers in the blood. Next. Clinical importance of the tumor markers, if you see, same thing what I told. For example, alpha fetoprotein. It is alpha fetoprotein. It is a plasma protein and usually absent in normal people plasma. It's a tumor marker for liver cancer and germ cell cancer. So in the condition of liver cancer, germ cancer, this alpha fetoprotein will be high in levels. So it is a clinically we can able to diagnose this is a liver cancer or germ cell. Next, calcitonin. The calcitonin is a hormone, but it is secreted in very less amount. If it is tumor marker of thyroid cancer, in the thyroid cancer, these calcitonin levels will be huge fold. So there we can diagnose the thyroid cancers. Thyroid cells is converted into cancerous condition. Calcitonin. Like that, carcinoembryonic antigen, CEA. It is a protein and it is a tumor marker for lung cancer, breast cancer, colon cancer, and pancreas cancers also. So it is a gastrointestinal related cancer marker. Once you got elevated, then differentially you want to diagnose which specific organism. Like that, human chorionic gonadotropin, HCG. It is a trophic hormone. Usually it is present in our system, little bit. In pregnancy, this HCG will be go very high. In non-pregnant, this HCG elevate means it is a marker of cancer. In non-pregnant women or in men, this level elevates, it indicates a germ cell cancer and or trophoblastic cancer. This is a beta HCG also we wish to call. And there is another marker, acid phosphatase. Sorry, there is a spelling mistake. Acid phosphatase, not TICE. It is tumor marker of prostate cancer. The prostate gland enlargement happens, then there will be a malignancy where it was acid phosphatase is elevated. Like that, high mobility group chromosomal protein, small molecular weight protein, expression protein, all those lot of markers are there. I am not listing all these things. If you're interested, you can go on the textbooks, you can read. A lot of tumor markers are there. The basic information is tumor markers are nothing but a marker which give information about the cancer diagnosis, detection, site, location. And at the same time, the markers also have disadvantages. The markers always also have disadvantage. What are the disadvantages? I'll show you next slide. Please, next slide. Disadvantage of the tumor markers are, these tumor markers are usually detect cancer at advanced stage only. So we cannot detect cancer in the early stage. Before cancer phenotype, before cancerous condition, we cannot detect this marker. So they are very little help in saving lives. Only in the cancer, it turns as a cancer, then only we can able to, not in the advanced condition. A given marker is useful in the detection of only one type of cancer. So one marker we cannot utilize for all diagnosing all cancer. It is very specific. Sometimes measurement of more than one type of tumor marker may be helpful or it may be required. So it does not exclusively help for the detection. It is a supportive marker, and also only in the advanced stage these markers, once the cell become cancer condition, then only we can able to detect, not in the before cancerous condition. So these are the disadvantages. But tumor markers are very much useful in detecting the patient's prognosis, treatment, modality, diagnosis, everything. At the same time, it also having the disadvantages. That's about tumor markers and cancer cell from myself. Any doubts, question you can ask, or else we'll close the session. Thank you for giving opportunity, Dr. Indra Madam and the team. If I given more time, I may come with colorful pictures. Yesterday evening only got told, so I am unable to prepare more slides. I'm sorry for that, and thank you all for giving the opportunity.
Thank you very much, sir, for your time and your excellent presentation. We will see you again, sir, in the next presentations. Thank you very much, sir. Good evening, ma'am.
Good evening. Well,
Let me invite Dr. J. Jasmine, ma'am, Professor in Nursing, Mother Teresa Postgraduate and Research Institute of Health Sciences, Government of Puducherry, with the 14 years of clinical experience and 20 years of teaching experience. Madam with 15 international journal publications and 26 national publications. She has attended 57 workshops and conferences, participated and delegated in 26 international conferences, and Madam has chaired many conferences, and Madam got many awards and medals like Mother Teresa Award and Indira Gandhi Shiksha Shiromani Award for Outstanding Achievements and Bharat Vidya Shiromani Award for Outstanding Achievements with many professional memberships. And I request Madam to present her topic. Over to you, Madam.
okay, thank you. Thank you for the introduction. And thank you so much for the organizing committee for giving me an opportunity, wonderful opportunity. That too after 5:40 p.m. Everyone is very tired by hearing lot of information to the knowledge. I know it. I think this topic is self-explanatory. It's need not to be too tight and all. It's very easy only. Our team is actually closing the gap in cancer care. Why we are giving the closing the gap means so many care we are providing in terms of community health nursing, medical surgical nursing and other nursing, but cancer is regularly increased because we are focusing on menopausal women, adolescents, girls, and other things like deworm and anemia care, everything. But we are not focusing much on what is that? Cancer. Cancer means it's after a long time only we come to know. That is why we are very much focusing on the closing the gap. Okay, may I have the first slide, please? That's the introduction. The next slide, ma'am. Slide, please. Can you share the slide? It's only that, or shall I continue?
Yes, ma'am. Yes, ma'am.
Slide is not going on. Yes, yes. Okay. Actually speaking, what are the gaps in cancer care? Cancer care, you know very well. And after coming to the clinicals only, we are taking care of them by diagnosing and other, for some complaints, they will come and you will diagnose as a cancer. But what is the gap? What is the gap in our care? Actually, gender norms and discrimination, it has some impact on them, and barriers of minority populations and the rural urban divide people, age discrimination, homophobia, transphobia, and related discriminations are there. Okay, that we will see one by one. Please go to the next slide, ma'am. Okay, gaps. Gender discrimination means what is the gender action? Actually, when compared to other group, that girls like misogamy. Misogyny means what? It's a prejudice against the woman. Misogamy means prejudice against the woman. If they have the cancers from cervix, cancer, breast, they won't come out of the family to show to your doctor. That is the one stereotype and expected gender roles. So certain culture and religious contexts may further limit the access of the timely care. Some of the stigma and from the particular group, that's a ostracism. That means from the particular group, they will not send the girls out at all, like tribal people and all. So that is in such conditions surrounding the CA, cervix. Breast cancers can make women reduction the CK cancer screening. They won't come for the screening at all because of the taboos and because of the culture. They will not allow them to out. That is the main gap. We are not. They are not mingled with our health people, our health professional to know the diagnosis and all. They won't say it out also. For example, white discharge. They may have months together. It indicative of chronic cervicitis and vaginitis, but they won't say it out. They will have some pad, and finally only if it is a chronic condition only they will come to know the health professional. They will communicate. In some part of the world, a woman may need tacit approval of permission from the male or head of the family. That is also there. So some of the family, they have to get the permission from the family head, like that may be a mother-in-law, or that may be a head of the family, or he may be a husband. They are depending of the others for the consultation with the doctor. It is again like a cultural taboo. Okay, what are the barriers of the minority populations? Minority population barriers is, that's a basic. For example, indigenous people living in 90% country of 90 countries, about 6% of the world population, but account for the 15 of extremely poor. Minority people means those who are below the poverty line, we can say, and those who are living in a tribal areas, and those who are living in the hilly places, they find it difficult to come out of the situation that we can say at the tribal. Okay, next one. Next slide, please. Rural, urban. That is a divide people, that the rural area, they face many obstacles. So rural area means they will not have nearby hospital. They won't have the knowledge regarding the prevention and screening, and they find it difficult to travel from the distance across 17 kilometers or 20 kilometers. The final burden also travel and finance, and they must take care of their children. And that is also, they find very great inconvenience. So that's a insurmountable. That means a great inconvenience to overcome all these problems. So as a result, they find very difficult. They will leave it for a long time. Finally, they reach the chronic stage. Then only they will come. That is one of the problem. That is one gap. Next is the age discrimination. The age discrimination, risk of happening with the age. Actually speaking, according to the age, when the age increases, cancer prevalence is high. That's very common actually. But nowadays it's affected the younger people also. 70% of the death caused by the prostate cancer, men aged over the 75 usually have more aggressive diseases. So because early some symptom is mistakenly taken, everyday pain or minor illness associated with the old age. For example, old age people, they have some of the changes, physiological changes according to the age, like minimized vision and hard of hearing, and physical aches like headache, and what is that? Find it difficult to walk. All these things will be there in the old age. Finally, it's diagnosed very later. They may have some problem. They will take much time to come to the doctor. They said that the age, because of the age I'm having like that, they satisfied themselves. Final stage only they are coming. That is also one of the gap. Okay. The next slide, please. Next is what is a health condition? The health professional condition, refugee status and the forced displacement. That means in some of the countries we are facing political, financial, and social instability, like war, social upheaval. That means a violent or sudden change or a natural disaster. In that condition, that cancer organization must deal with the harrowing shortage. That means acutely distressing shortage of the staff to complete the breakdown of the health services. They will go for the service where the disaster occurs. Less importance was given to the such a patient. That is also one of the gap that we may not aware. When they complain means, okay, because of this only you may have the like that, we may delay them. Next is homophobia. Homophobia, transphobia, and related discrimination. Around the world, some of the discrimination are there for the transgender, lesbian, and then homosexual behavior and strange people. So in that condition, that the discrimination around them make them to find it difficult to come to the hospital. They are more likely to face ignorance and outright prejudice of the health practitioner. They will have some prejudice, they won't come. That is also one of the gap. Okay, next. Next slide, please. There are 6 factors. These 6 factors is common for the gap. What the 6 factors we told? What are the 6 factors we told? Gender norms, barriers of minority populations, rural-urban divide people, age discrimination, refugee status, and transphobia and related discrimination. All these things, 6 factors. So few days people are over the world. In all this world, these people are there. We find these are the some of the barriers to give the cancer care. Okay, but all these things we can overcome. There is a hope. How we can overcome that, we will go for step by step. That is we have to solve the inequity among the care, that we will see it. Okay, next slide, please. Problem to solve. What are the problem we have to be solved? Problem to be solved is social determination of health. What are the social determinations? The prevalence, actually, gradient the prevalence and the burden. We can go for the survey and we can recognize the prevalence and burden of the cancer. And then inequitable person, community resource to cope with cancers. Community resources means the community people, those who we are going, we must have some protocol to assess the CA patients. For example, we can allot the studies for the PG students, identification of CA cervix by means of acetic acid test, and you can go for the survey of the particular area who are having the PID, pelvic inflammatory disease, and other complaints like that. We can go and assess, and we can avoid the inequitable. Next is inequitable care. Patient expensive. The problem which we have to solve is discrimination in the equitable rates of screening, inequitable barriers along with the patient journey, screening, diagnosis, treatment, post-treatment support, specific barriers like language, cost of medications, and transport and ancillary care. All these things is a problem that we have to solve. How we can solve all these things? We can come across by integrated system, best quality for all by geared different greater needs. We can recognize and we can go for the needs, like moving, if the care is moving, that we have to take care of all those things. Next slide, please. Towards the solution, how to solve all this problem. Okay, to identify the gaps, we can act on them. Some of the things we have to do, like tool list. We set out a tool list of ideas, directions, and tools to build equity into cancer care planning and delivery. What is that we have to plan? We have to plan what are the aspects we can do, like a protocol or software. Also, you can keep as an app. You can keep what are the checklists we can do on the CA mothers, and solidly based on research, evidence, and yes, best practice. Some of the things we would have got evidence. What are the evidence you can have? Any idea? Chronic bleeding, chronic cervicitis patients, they will have this one. And recent some of the studies also, those who are there is a study conducted long back when I did my UG program in MMC. Our seniors conducted a study. What that study says means, can you hear my voice? Yes? Can you hear my voice?
Yes, ma'am. Yes, ma'am.
Okay. The recently, I told it's 20 years back, they have conducted a study on CA uterus. What they find out, no, they conduct comparative study between the women, those who are using napkins, sanitary napkins, and those who are using clothes for the periods. A comparative study. So in that they find women, those who are using clothes are having much cervicitis and prone to get cancer, because they are not washing the clothes properly. If they wash also, they are not put under the sunlight. So fungal infection is very common in the clothes. Again, they are keeping the clothes. It's a major source of infection. Repeated chronic infection leads to CA cervix. They have proven that one. So what I want to say is, some of the things we can go for evidence. Repeated para and poor hygiene. But recently, maternity hospital, we observed one woman, she came with inskirt only for the periods time. When we asked why you are not using any clothes or napkin, but she says, no, it's our practice. Our practice, we use inskirt only for periods time, but we sat alone in the room. Like that, she is telling how it can be a hygienic one. See the attitude of the people. But what we can say, so many newer technology came also. Some of the people interior village, they are very much innocent about the menstrual hygiene. So we have to form one protocol. What they will say, the sister came from the hospital, they have given so many protocols that I am following. Now I feel comfortable. Like that, they must have the tendency. So solidly based that when we enter the room itself will give some blood smell. How the infection will have. So imagine the situation that we have to formulate solidly based research, evidence, and of the years, and action-oriented, manageable, measurable, and it monitor the things. What we are doing, the evidence-based study is measurable only. What are the studies we can conduct to help the CA? We are finding so many cautions and so many signs we are recognizing that, and all we can go for the studies. Okay, next slide, please. Start from solid foundation. Solid foundation means what we can say, high performing healthcare system, whether cancer care is province wide, build equality in all planning and service delivery. It's not meant all the programs. You are conducting so many programs in the community. What are the programs you are conducting? Simply you are conducting school health day and mega mass health program, and then DWAM program, anemic program, supplement of folic acid program, and supplying a napkin to the school children. Whether they are using or not, you are not bothered, but you are supplying. Is it not? And you are taking care of AN mother, PN mother, under 5 children, all those things, and cancer, diabetic patients. But who is taking care of the cancer patient? Who finds any initiation to do all these things? So you must, the first thing is, we must have the concrete idea. Planning and the service, how to do the programs, planning, take equity. Because when compared to other care, we are not equally contributing time for the identifying of the cancer. Okay, so you have to do that one and need clear strategy, commitment, action. Strategy means action, clear-cut action, building equity into the system as a whole. For example, that the cascading throughout all providers and the program, so that we can do that. Cascading means repeated measures. We are going for repeated measures for so many things, but not for this one. For example, growth chart we are maintaining. What it indicates, the growth chart in the 5 months, this baby weight gain must be like that, but he gained weight to this much. Continuously up to 1 year you are monitoring. And then you are observing whether the baby has vaccinated properly, complementary food they have started or not, whether the mother is giving breastfeeding or not, that and all you are observing. Is it not? So for that you are formulating one chart or one protocol. Same like we have to formulate one protocol or one chart for the recognizing of the cancer patients. Are you clear? So otherwise the patient also may feel afraid of this one. Sister is coming and she's talking about cancer and all. It's not like that. Okay, next slide, please. To practice through equity focused planning. Equity focused, addressing disparities in access to or equality of cancer care requires a solid understanding of contours and scale in inequitable outcomes. I told you the scale. Scale means that some of the statement you have to mention and you have to monitor. Specific needs, health disadvantages of the population, gaps in available service for these populations, key barriers to equitable access to highly care along patient journey. And at delivery level, consider the equity in all program planning, given the importance communication and understanding of everything. I told no, you have to formulate one outline. The contours means outline or a boundary for your assessment and your care, your strategies, and you have to plan. Okay, according to that, you can implement. Okay, next slide, please. Next slide is actually equity data, how to collect the equity data. Because our blame is we are not giving equal. We are giving gap to the cancer care. For that, we are going like that to need solid equity oriented data to identify the gaps in the needs of the disadvantage of the patient, to measure and monitor the progress. And some of the studies we can conduct regarding this one, how to measure, how to monitor the progress. Okay, next slide, please. Build knowledge we can act on. That is the knowledge. Every health professional, we have to include the research-based knowledge, like epidemiological scale disparities, community-based research. I told you, Many of our PG students, we used to do the acetic acid, vaginal acetic acid test in the community. Out of the our 250 cases, at least 1 or 2 will be positive. And remaining out of 200, 100 patients may have the chronic cervicitis. Cervicitis like have the white discharge. It is a pre-stage cancer stage actually. They may not bother. They are thinking that white discharge is normal. Their concept is white discharge after 45 years normal. Why you have to bother? They are having like that. So the itching will be there. Itching is one of the indicative of diabetes. They are not bothering that also. They will wash with Dettol. They will go for some other indigenous medicine and they will take some greens. Some may go for some other insertion also. That and all we should not encourage. Next is ethnographic. That is a nonsense of experience. Nonsense means substantial difference, little difference of experience along with the patient journey. Along with the patient journey, each patient will have the different opinions. Evaluation need to know the work well with the population varying context. So each people will have different ideas. We have to recognize what it is. We have to try to fill the gap. Okay. Next slide, please. Beyond the planning. Next slide, please. Dan. What is that person? Embed. Embed means what do you understand by the word embed? Embed means strongly. What means firmly? We're firmly fixing into targets, deliverable, and performance management. We are planning beyond the so many plans we are having, but we have to fix a target very firmly. Okay, in that clear consensus. Consensus means general opinions from the research and policy literature and consistent features in comprehensive health equity policies from other jurisdiction. Jurisdiction means a judgment or a decision authority. Like WHO, they will recommend things, and the Cancer Society, they will recommend something. Because of long experience, they are recommending. So we have to update our knowledge by seeing all those things, and we have to implement to the society. Developing realistic and actionable indicators for more equitable service delivery and outcomes, setting targets for reducing access differentials, improving the health outcomes of particular populations, monitoring progress against the target and indicators, disseminating the results widely for the public scrutiny, and then performance, beginning the performance with the funding incentives. When we are going to doing something means we can give some incentives also, those who are very active, and they are giving the suggestions. Okay, next slide, please. It's a success condition. What are the equity targets? Effective. Innovative work underway to develop the equity indicators. Don't need to wait. Pick up the what is most relevant to your contest. Our contest, what is the most relevant? Because you will go for different area, no? Different area, what the people practice there, what the lacuna there, whether it's based on the ethnocultural, geographical level or differences, you could target, you have to observe, and socioeconomic status, according to that, you have to give the strategies. Okay, next slide, please. Equity into organizational and system drivers. That is a quality improvement is a major provincial and system priority embedded equity. Equity, repeatedly we are saying, because a part of the equity and equity customized care to meet the different needs. We are recognizing different needs of the community and the patients, and we have to fill the gap by means of identifying the needs. Social determinants, disadvantages, populations face greater barriers beyond the hospital walls. Already we have told that the available, they find it difficult to come across because of the transportation, childcare, food for every day they have to go for job, then only they will have the food, inequitable access to the community service, discrimination, being they able to afford medication. They could not able to find the medication. Because what is that access to community so inequitable? When the community health nurse visit that place, these women may gone to job. Some other job, they cannot meet them. That is so what the next step we have to do? We have to go for the industry to visit the woman. Next, effective continuum of care and effective navigations, transition, etc. that we have to do. Okay, next slide, please. Next, actually, what are the use of proven tools? These are the use and proven tools for equity standards in cancer care. First one is build equity in the strategic planning policy development. and then human resources policy and recruitment practices, and then incorporate cultural competence into employee education. I told you, cultural competence into the employment education. They will have the different culture, they will have the different practices, and you have to educate the employee to achieve. Okay, engage communication. Next is ensure the equitable access to healthcare. Access to healthcare means engage on the outreach to marginalized communications. And what are the things we are telling that they must be reached to the community, and mitigate the access barriers. Create navigations, referral networks for marginalized community. Marginalized communities mean those who are living in the outreach of our place, like they may not be in the rural area, they may not be in the urban area, they will be there in the inside some hilly places, and they are interior village where they could not, they find it difficult to come to the main places. That people we have to do. And then ensure the equitable quality of healthcare. It's provide culturally competent care, build equity into child, family, and patient-centered care, provide interpretation communication supports, and build build a future into that one. Okay, next is the monitor and evaluate the drive improvement and maximize the impact. What are things you are doing that we have to monitor, and we have to assess, and we have to go for the maximize the impact. Monitor population health inequities, service accessibility and utilization, conduct research needs assessment to the identify unmet needs, assess barriers, service gaps, conduct health equity impact assessment program, service evaluators. So what we want to see means we have to conduct many research studies. What is the need actually, where the assessment we need, what are the unmet needs of the patient, how to manage the separate the to bring out the equity standards. Okay, next slide please. That is an indispensable foundation for equity into quality, cultural competence. Indispensable means absolutely necessary. This is very important, very necessary to increase a diverse society. Diverse society means very different society. High quality care, culturally competent care. Society means it is going on changing. Recently, ASHA workers, they went to give vaccination to one family. That family member scolded her very nicely. Why you are coming? Who asked you to come? If you put vaccine also, I'm getting COVID. If you're not giving vaccine also, we are getting COVID. If you are because of your vaccine only, we are getting COVID. Your vaccine is giving fever. Your vaccine is giving temperature. Your vaccine is giving throat infection. Your vaccine is giving positive. Like that, in the street road, they are gathered 2 or 3 members and shouting her like anything. So what I want to say is society is not acceptable or palatable as previous those days. In the 80s, 70s, the family were different. What they will say, sister has come, we have to take care of the sister. What sister, what I have to do? Like that they will ask. Nowadays, they don't want. If they are there in the home also, no one is there in the home. Sister, we are in the busy, you can come afterwards. So that is a diverse society. They are, moreover, their previous days, the health profession is the only personal providing the health information. Nowadays, it is not like that. They are getting from many places. They are going for the internet, they are going from the nearby houses, and they are going for some other place. They're seeing the films, they are getting the information. So that is a problem again. We are getting the diverse society. Means building the equity and the diversity into all facets. Facets means to one side of service delivery. Customizing care to address the language and other barriers people may face and their cultural preference and needs. We have to recognize the cultural preferences also. For example, non-sister, they won't allow us to do exam. They won't ask us for the PS surgery. They won't encourage for the sterilization. You know, their culture is like that. Okay. And where a structure analysis, knowing the patient meets equality care and just service delivery, but everyone, everywhere we have like a security service, receptionist service, everywhere. Plus organizational commitment, like supported by the resources for training, linked with the concrete performance expectations and deliverable. what is that thing they want to say? Means we have to undergo some specific training in the commitment. Okay, next slide, please. So use available levers. That's a common one. Use available resource means what we are having. It's available resources. Equality should be one dimensions providers must report on, but was not really hospital planned so far. That's called the missed opportunities. No reason why the individual providers can't decide the incorporate equity into the QIPs. QIP means what? Qualified institutional placement. Okay, qualified institutional placements. Immediate benefits embedding equity, improvement of necessary cross-hospital collaborations and discussion may help the embed the equity. What is that collaboration and discussion? Collaboration and discussion will help. Any hospital, they will go for camps, eye camps, cancer detection camps. That camps and all will find out the collaboration with the hospital service, and they will give the adequate care. Okay, cancer institutional build equality into their QIPs. They will qualified institutional placement. They will go for weekly ones for a community visit like eye camp, cancer camp, and they will find out the disease condition. Next one is the 7-8 target access and quality barriers. What is that target access? What do you mean by that? Improving equity requires identifying and addressing specific equity barrier. So within the delivery, that means language, lack of understanding of different cultures, differential treatment, prejudice, and discrimination accessibility. It's very, very difficult task to bring them out of their prejudice. They will have the concept regularly. It's for example, one mother, she's having DUB. DUB means heavy bleeding, and she's not willing to come to doctor. What she is replaying, no, the prejudice I want to say. For 10 days, 15 days bleeding during the menstrual period is normal. Why I have to meet the doctor? She's telling simply, 15 days, sister, 20 days bleeding. It is normal only. In the menopausal age, it will come. Why you ask me to go to doctor? She may become severe anemic. She finds difficult to cope up, but she will say, I won't come to doctor because it is normal. Same beyond the hospital. Send the home and the follow-up. We can go for the follow-up prescription, but we cannot give the drug plan. And we can refer to them for the clinic follow-up because the family responsibilities are also there. And most important barriers will vary. That is back to importance of data and understand the health needs of the community. We will have one need, we will recognize one need, but the community need may be different that we have to recognize. Okay, next slide, please. Barriers. That is underserved population. Underserved population means what it understand. They are below the poverty line and underserved. They are receiving very minimal care. Okay, we have to, the solution is focused community partnership. Lower screening rates, particularly in the ethnoculture. I told you, some of the place they will live in the hilly place that now should walk more than 15 kilometers to reach that home. So they find it difficult how they will go and how they will detect. They will conduct one camp also, they won't come. So the community-based research to assess the and broad partnership of public health. Though some of the studies also saying that uterus function is to receive the baby. During the service, they have to feed at least 36 months. The mother who delivered more than 5 children, more children has got high immunity power. Whereas mother who deliver 1 or 2 babies, we don't have much immunity power. So see that is why that older people, they're having 7 kids, 8 kids, the mother was healthy. Mother were healthy. Nowadays, everyone is giving birth to 1 or 2, they are not healthy. Mothers are not healthy. These are some evidence-based. Okay. Public health providers and trusted community organizations to get the beyond the barriers and outreach of diverse community setting. So, somebody is speaking there. Somebody is speaking. I'm coming to the last. Next slide, please. Okay. Next slide, please. Build community partnership with solution. Addressing wider social determinants of health and roots of the healthcare communities means working in broad partnership. Broad partnership means with others like volunteer organization, Red Cross Society, and cancer organization, and Somebody is talking back. Some talk is going on. Somebody is talking. We can go for unmute. Okay. So can better collaboration with the community agencies like voluntary service. This slide actually, like voluntary services, cancer society, voluntary organization, we can do one good continuity of the care transition and we can give. Okay. Next is actually pull all this together into strategic roadmap. That's an important components. We all together target access quality, barriers, strategy use of available levers, collect the equity data, equity focused planning, partner, put together into equity plan, solid foundation. From large toolkit, we can develop a roadmap. And it cannot be a rigid blueprint. It can be flexible, adaptable, implementable to all, but need to sense of direction, overall goals. Okay, what are the goal today? Last one. What are the goal today? Next slide, please. Goal is land on action initiatives. Our goal is to prevent the gap. Is it not? Closing the gap in the career. Adapt the implement equity relevant data, systematically collect across the system, build into measurement and monitoring. Always we have to monitor, build equality into system and provided performance management, adapt most relevant indicators, deliverable and incentives for the context, use proven tools like standards. We can get it from the WHO and Cancer Society, and we can implement for our society. HEIA. HEIA means what? Health Equity Impact Assessment. HEIA means Health Equity Impact Assessment to operation and build community partnership. So all these things we can come across today. So finally, I want to tell you what is the nurse's responsibility. So many things we are learning, is it not? Like a gap, we have to closing the gap between this. So what is the responsibility of the nurse? Nurse must be aware of the warning signal. Warning, you know, as caution us. It's not only caution. You told caution, no, caution as US. Caution, you know, change in a bowel habit, your sore that does not heal. U for unusual bleeding, T for thickening of mole or lump, I for indigestion, O for obvious change in the voice and in the words or mole, nagging cough for N. As US means what? What do you understand by the term as? It is not there in the slide. What do you mean by US? US means U for unexplained anemia, S for sudden weight loss. Okay. U for unexplained anemia, S for sudden weight loss. So all these things caution us. You must be thorough. Okay. What are the things we can do? We can do as door-to-door visit. What we are doing for nowadays for this one. Like this for the immunization, like the door-to-door visit, regular camps to detect that cancer and awareness program about warning signs. We can say about the warning signs, explain about the early detections, prevention of complications. We can say about the early diagnosis and nurses' responsibility. We can reduce the inequality by means of education the people about the cancer prevention, equipping healthcare professionals with skill and knowledge. We must be equipped by means of adequate knowledge, strengthening primary healthcare communities, addressing through policy and program. We have to address the root cause of inequalities. We have to recognize the root cause for the inequalities and to treat cancer as an important health issues by challenging the stigma and prevented by implementing evidence-based strategies for cancer prevention, screening, early detection, treatment and palliative care. Modifiable risk factors like tobacco use, alcohol, lack of physical activity, low fruits and low vegetables intake. We have to ask them to modify specific risk factors like chronic infections for human papilloma virus and cervical cancer, hepatitis B and C, liver cancer, H. pylori for the stomach cancer, prevented by decreasing prevalence of known risk factors and vaccination also. intervention for tobacco control and HPV vaccination. Studies can be conducted regarding cancer risk factors and preventive measures. And we must be aware of, we must update our knowledge regarding cancer regularly because advanced technology has come into practice. We are the community health nurse, research nurse. We have to do the maximum to fill the gap, closing the gap in cancer care. Thank you so much for your kind patience. For a long time, you were keeping quiet and observing my class. Thank you so much.
Thank you, ma'am. Thank you very much, ma'am. You have explained in detail and we all gained in-depth knowledge about the cancer and how to close the gap in community area, in the hospital area, and you have shown the road mapping and you have explained indeed a lot of examples also, ma'am. Thank you so much. So it is very, very useful for us, ma'am. Thank you very much.
Thank you for giving me an opportunity.
Thank you, ma'am.
Especially to my scholar, become Dr. Kanta.
Yeah. Thank you, ma'am. Thank you.
Thank you so much.
Thank you.
And your principal, convey my regards to your principal.
Yes, ma'am. Yes, ma'am.
And you people are anchoring very well. One girl nearby you with respect, she is also with a smiling face. She is so beautiful and she is explaining well. And you also, thank you so much to everyone.
Thank you. Thank you.
Now let me invite the next speaker, Mrs. Kanta ma'am, working as a professor in community health nursing department and involving clinical education needs as per the curriculum. And she is much involved in the research activities with 63 original research publications and 7 book publications and 133 Google Scholar citations and many more endeavors in her career. I welcome you for the presentation, ma'am.
Thank you, Mrs. Usha, for the great intro. A very good evening to respected principal madam and my guide, Dr. Jasmine madam, Dr. Tiruna sir, Dr. Ramalingam sir, and all my dear colleagues and lovely students. A very good evening to one and all of you. So today we are conducting this program on behalf of World Cancer Day. So we are trying to close the gap in care. So let me see the topic. So my topic for this program is prevention and control of cancer. So what is this cancer? So here by all of these presentations, we came to understand that a single abnormal cell multiplied out of control. So it will be forming like a tumor, invading healthy tissues and spreading to other parts of the body. Okay, so by this time also I don't think that I can explain this definition to you because all other previous speakers, they have told all these things very nicely. Risk factors, these things. Okay, so under this epidemiology also have listed the Asian factors which were very well explained by Dr. Tiruna. So coming to my topic in particular, so that is prevention and control of cancer. So here in community and in health setting, the prevention can be divided like under 4 modalities like primordial prevention, primary prevention, secondary prevention and tertiary prevention. Okay, so what is this primordial prevention? So primordial means what here? So here, all the measures that we will be taken before the occurrence of the disease causative agent. Okay, so that will be called as primordial prevention. So that means what? So before the occurrence of the disease causative or the risk factor, okay, like in the individual, the risk factor will not be seen. Okay, the individual will not be knowing that, so that risk factor will cause to him. Okay, so at that stage itself, if the individuals are taking precautionary measures, okay, like the best example, doing yoga, okay, or so for what? To remove the stress. Okay, or other example is like the people can be made aware about protecting from carcinogenic exposures and danger signs of cancer with the health education. Okay, and another example is like women can be educated about warning signs of cancer of cervix, such as bleeding after menopause, bleeding in between menstrual period. Like young girls in particular and women in general should be taught menstrual and genital hygiene for prevention of cancer cervix. Okay, so like primordial prevention means what? Before the occurrence of the risk factor itself, we'll be taking some of the measures in order to eliminate the risk factor. Okay, so such kind of thing will be called as primordial prevention. So here, like even educating the children or the adolescents, okay, are establishing good habits and lifestyle among the children. And here we will be explaining them regarding what are the hazards of smoking, alcohol, benefits of exercise, healthy diet, okay, or exposure to the danger signs of cancer by the health education. Or women can be educated about the warning signs of cervix. Okay, so like this health education will also come as a primordial prevention. Okay, next is primary prevention. Okay, so the next step is the secondary stage of prevention is primary prevention. So under this, mainly high risk strategy will be there. So what is this high risk strategy? So this is aimed at bringing preventive care to those people who are at special risk of getting cancer. Okay, so that means what? Like for example, the individuals who are working in the textile industries. Okay, so they will be at risk to get like carcinoma. Okay, are the people who are having the habit of tobacco. Okay, or like who are seeing the others who are having the habit of smoking, are the people who are taking like eating beef or alcohol or smoked fish, or who are having the risk to expose to the carcinogens. Okay, so to them, like we will be identifying them and we will be making them to take the precautionary measures in order to prevent the occurrence of the cancer. Okay, so that will be coming high risk strategy. So in the name itself, there is meaning high risk strategy means identifying the high risk people and will be giving them the measures through which they could able to escape from the occurrence of the cancer. So here the nurses can teach the following high risk groups like to quit smoking and stop chewing tobacco. Alcohol intake should be restricted, to have only one faithful married partner, family history of breast cancer, change the dietary habits. Women should have marriage at appropriate age. Okay, high risk individuals should be educated regarding all these things. Like the women should have pap smear test for screening cervical cancer. So these things will be coming at a high risk strategy. Next one is population strategy. So what is this population strategy? So cancer education to general public regarding the warning signals of cancer, which are the following, like a lump in the breast, a non-healing ulcer of more than 2 weeks duration, a change in molar bond, a persistent cough, a lump in the testicle, unexplained loss of weight, difficulty in chewing and swallowing. So here, for this like here in the population strategy, we will be like focusing a group of people here in order to make some change in the group at a time. Health education to people regarding the following, like maintaining personal and genital hygiene, exercise, performing breast self-examination, testicular self-examination. So these can be encouraged at a population strategy. So next, avoid exposure to radiation. So special efforts should be made to reduce the radiation amount received by each individual to a minimum without reducing the benefits. Health education. So educate to use fruit, vegetable intake. Do you know? Here in our daily life, we have to take fruit or vegetable for about 500 grams per kg. So that is half a kg. Okay, so here it can be included like fruits, vegetables, legumes, whole cereals, and we have to avoid such kind of foods like junk foods or avoiding very much high caloric agents or fatty food should be avoided. because according to some of the research studies, they are saying that even high fatty diet can also cause the cancer. Next one is treatment of precancerous lesions. So early detection and prompt treatment of precancerous lesions. Example, cervical tears, intestinal polyposis, warts, chronic gastritis, chronic cervicitis, and adenomata should be sought for preventive cancer. Next, specific protection. So what is this specific protection? Avoiding X-ray and radiation exposures by wearing protective devices and rotational workers if harmful effects are found after every 2 monthly examinations. Industrial workers should wear protective devices, apron-like gloves and respirators to prevent certain specific cancer vaccines are available. Okay, so here the vaccines can also be encouraged in order to prevent the occurrence of cancer. And in some of the industries, we could able to see even the legislative and restrictive measures, like Government of India has enacted an act, the Cigarette that is Regulation of Production, Supply and Distribution Act of 1975 states all the persons trading in cigarettes have to display a statutory warning prominently. That is, I think all we are knowing, like cigarette smoking is injurious to health. So legislative measures to control air pollution also exist, aimed at prevention of lung cancer. Legislative measures to protect occupational workers from cancer hazards also are enacted in the Indian Factories Act 1948. So this is about primary prevention. Next one is secondary prevention. Usually the secondary prevention will focus on early diagnosis and prompt treatment. So here under early diagnosis, what we are having like cancer registration. So it includes a baseline data recording magnitude of the cancer problem and for planning and implementation required services. Okay, so here mainly these are two types. What are they? Like hospital-based registries. Okay, so that means what here? So that it includes all outpatient as well as inpatients on treatment in the hospital.
சின்ன பிடல் தான் வேலை மனையட்டி வச்சது கால்ல நீ ஆட்டா வச்சுக்கணும்ல.
Nana Prabha, please mute yourself. Sorry for the interruption. So here the registry, like hospital-based registries, it includes all outpatient as well as inpatients on treatment in the hospital. It should be done as per WHO handbook for standardized cancer registers, and population-based registries, like it should include the situation in a given geographical area. Okay, so like here hospital-based means what is the difference between hospital-based and population-based registries? In the hospital-based registries, the patients who are coming to the hospital, they will be registering, and population-based means so in the community setting, so these registries will be taking place. Okay, so here as we have discussed, the secondary prevention, early detection of the cases. So this is done by the cancer screening at a stage where the lesion is localized. Okay, so here the individual will be having the signs and symptoms of the lesion, so here they will be presenting to the hospital with the complaints of that lesion, open lesion. So here the early detection of the cases will be taken place. So next, the second part of secondary prevention is treatment. So what is this? So treatment of cancer include mainly the following methods. What are they? Usually surgery, chemotherapy, radiation therapy, immunotherapy. So this is secondary prevention. Okay, so secondary prevention means mainly it includes two things, that is early diagnosis and prompt treatment. Next one is tertiary prevention. So the tertiary prevention aims at disability limitation and rehabilitation. So what is disability limitation? So this is done by intensive treatment to prevent development of disability. Patient may develop disability due to pain, decreased vitality, loss of weight, fatigue, and discomfort in advanced stage of cancer. Next, rehabilitation. So patients who have undergone surgery are rehabilitated. After amputation of leg, they are given processes and physiotherapy in order to train them to walk with processes. Rehabilitation also includes management of psychological problems of the patient and management of the social, spiritual, and family problem. Okay, so we will be thinking that talking to the patient may be a minor aspect, but it costs a lot. Okay, so they will get the giving psychological reassurance patient to the cancer patients, like it plays a major role to relieve their stress, okay, and to express their inner feelings. So then let me see some of, so what are the other types of cancers, and so how the magnitude in our India and how we could able to prevent it. So first let me see the oral cancer. The oral cancer has a high frequency in Central and Southeast Asian countries. So what is the magnitude of this problem? In India is an estimated incidence of 9.8 cases per thousand population for males and 5.2 cases per lakh population for females. So the epidemiological features, it includes the factors associated with oral cancer, tobacco chewing or smoking are linked to oral cancer in about 90% of the cases. So alcohol has a synergistic effect in the tobacco for oral cancer. Next is cancer cervix. So the problem in India, cancer of the cervix is the most common cancer among women globally. The Global 2008 reported an estimated 530,000 deaths with overall incidence. Mortality ratio of 52% in developed countries. So the number of cases and deaths has declined due to reduction of risk factors and early detection through the screening programs. So the cancer of the cervix is a leading killer cancer among the women. The incidence rate of 27 per lakh population and mortality rate of 15.2 lakh population has been reported. So the natural history if you are taking, so it is observed that the cancer of cervix begins with epithelial dysplasia and progresses to the carcinoma in situ to invasive carcinoma in 15 to 20 years. So the causative agent is HPV, sexually transmitted, is evidenced to be the cause of cervical cancer. The virus is found in more than 95% of the cancers. So what are the risk factors for this? The age, women between the age group of 25 to 45 years are more affected. Genital warts, present and past occurrence of genital warts is a risk factor for cervix cancer. Marital status, early marriage, so early childbearing and repeated childbirths have been associated with increased risk of cervix cancer. Oral contraceptives, a WHO study has found that users of oral contraceptives with estrogen have increased the risk of cervix cancer. The socioeconomic status, more common among women with lower socioeconomic status, probably due to poor personal and genital hygiene. Prevention and control, so here it can be by early detection of the cases and the prompt treatment. Next is breast cancer. So the problem in India is most frequent cancer among women with 1.38 million new cases diagnosed in 2008. So the risk factors for the breast cancer are like unmarried women, delayed marriage, obesity, hyperthyroid, lack of exercise, high level of estrogen, family history of breast cancer of mainly first degree relatives. So prevention. Primary prevention, health education to eliminate risk factors can help in preventive cancer of breast. Promotion of physical activity, decreased fat intake to prevent childhood obesity can help to prevent breast cancer by increasing the average age of community. So next level of prevention is secondary prevention. So secondary prevention includes all the measures taken as for the treatment of general cancers. So lung cancer. So the problem in India is, so death rate due to lung cancer is increased by 76% in men and by 13.5% in women. So here so we could able to prevent it by includes the measures to control smoking. WHO expert committee 1982 has described various methods to control smoking epidemic. So next, so under primary prevention of this lung cancer, information, education and communication. And so we also know that there are so many legislative and restrictive measures are also present. So coming to the role of the nurse in cancer prevention and control. So the nurses are the central to healthcare delivery in all disciplines in oncology. Is no exception. Nurses are crucial members of the healthcare team in cancer prevention and control through their lifespan. To prepare nurses for this major role, education programs in cancer prevention and detection must be introduced for all nurses. So the components of cancer control, like as we have discussed, prevention, early detection, treatment, and palliative care. So the more emphasize, so here we have to emphasize about the risk factors, how to deal with the risk factors, history, screening, and simple set of questions. More focus on client education through the lectures, leaflets, posters, etc. Multidisciplinary team approach, more community involvement is needed. So the WHO is emphasizing these three things, that is discovery, development, and delivery. So here whatever we are inventing through the research, so that we have to develop through the translational science, and we have to deliver at 3 levels, 3 important levels. So that is oncology practice, primary care practice, community health practice. Thank you. Thank you for the great opportunity.
Thank you, Kanta, for your detailed explanation about the prevention and control of COVID-19. And now I would like to propose, I would like to invite Subhashini to propose one of the topics.
Good evening, madam. Greeted, madam. No, madam, I am the last person. Next time. A warm good evening to all. I deem it a great honor and privilege to propose vote of thanks on this occasion. Let me first of all start by giving glory to the Lord Almighty for making today's virtual program on the occasion of World Cancer Day a resounding success. I must mention our deep sense of appreciation to Principal Narayana College of Nursing, Dr. Indira A. For being the catalyst that stimulated us to do our best and standing as pillar of strength. I am immensely thankful to our principal, Sri Narayana Nursing College, Professor Jayanti ma'am, for her encouragement in all our efforts. I would like to express my heartfelt gratitude to Dr. Tirunavakarasu, MS, MCH, Department of Surgical Gastroenterology Consultant, Narayana Super Specialty Hospital, who despite his busy schedule has found time to grace this occasion to disseminate knowledge to today's gathering. I extend my special thanks to Dr. Ramadevran Sir, Professor of Biochemistry, Principal of Allied Health Sciences, Central Laboratory Coordinator, Narayana Medical College Hospital, for gracing the occasion and sharing his knowledge with us. I also wish to express my sincere gratitude to Dr. J. Jasmine ma'am, Professor, Department of Medical Surgical Nursing, Mother Teresa Postgraduate and Research Institute of Health Sciences, for her informative presentation on today's theme. I also extend my warm thankful gratitude to Mrs. K. Kanta ma'am, Associate Professor, Narayana College of Nursing, for her excellent speech and prevention and control of cancer. I also extend my heartfelt thanks to Mrs. Lata ma'am, A. Professor, Head of the Department, Medical Surgical Nursing, and all the Medical Surgical Nursing Department staff members for their enormous cooperation throughout the organization of this program. I also extend my warm thanks to NSSL Program Officer, Mrs. Usha Kiran, Associate Professor, for the collaboration with the MSN Department for successful completion of this program. My heartfelt thanks to head of the various departments and all faculties, colleagues for their valuable presence in the program. I extend my gratitude to all dear lovable students for your active involvement in the program. Our sincere gratitude goes to all parents and well-wishers and for encouragement throughout successful function of our organization. Thank you so much for attending this event. I would also like to thank the people who worked behind the scene to make this event happen. Our technical arrangement team, Mr. Nagarjuna and Mr. Lakshman, for their support. Last but not the least, I thank all the participants who participated enthusiastically and make the program success. I would like to thank you once again for making this program a grand success. Thank you.
End the program with the nation.
Now we will end the program with national.
जनगणमनाधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभाशिष मागे गाहे तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय जय जय